Dr. Ritika Goel. Yeah. She has a travel plan, so she's going to do first. Her case is case report of ruptured orbital hemangioma, mimicking orbital cellulitis. Go ahead.
Good morning everyone. Let me tell you a story of a 18 years male who presented to our OPD with complaints of pain in left eye followed by swelling and blackening of left upper lid and diminution of vision, which was sudden in onset. It was associated with 3 episodes of projectile vomiting. There was no history of recent trauma, fever, headache or sinusitis or any other systemic illness. But they told that 5 years back he had trauma to left eye by fist, which was followed by swelling and redness of left eye. Since then, family members have noticed forward protrusion of left eye on lifting heavy weight, pressure over abdomen, sleeping in left lateral position, and during forward bending. These are the file photographs and videos which shows protrusion of left eye on applying pressure over abdomen. General and systemic examination was unremarkable. Visual acuity at the time of presentation was finger counting close to face. NCT could not be recorded due to swelling. Extraocular movements were limited in all gazes and grade 3 RAPD was present. Slit lamp examination shows blackening and swelling of upper lid and diffuse subconjunctival hemorrhage with chemosis. Rest all anterior segment examination was within normal limits. Posterior segment examination was unremarkable. IV antibiotics were started, followed by MRI brain with MR virogram, because at this stage we were suspecting it to be orbital cellulitis. And surprisingly, here was a miracle. Within 6 to 12 hours, the swelling subsided, chemosis reduced, visual acuity regained to 6/6. Extraocular movements were full in all gazes except some limitation in lateral gaze due to chemosis. Follow-up examination shows resolving chemosis, subconch hemorrhage present, pupillary reaction was normal. On day 2, IV antibiotics was stopped and patient was shifted to oral antibiotics. MRI brain shows hemangioma in left intracorneal space, proptosis of left orbit, lesion encasing the optic nerve but signal intensity of optic nerve was normal. You can see fluid tracking along the left LPS which is suggestive of rupture, multiple blooming foci within the lesion that is phlebolith. So a diagnosis of ruptured cavernous hemangioma was made. A follow-up MRI was done after 1 month to look for this progression of the hemangioma. After 5 months when patient came for follow-up, he complained of mild forward protrusion of left eye during sleep. There were only 1 to 2 episodes which resolved spontaneously. We can see apparent in ophthalmos, deep superior sulcus, and on valsalva there was subtle filling at the site of superior sulcus. Herter's exophthalmometer reading at base distance of 30 shows right eye 20 mm and left 17 mm. So, the catch is here. Clinically, it is presenting like varix with intermittent proptosis, distension on valsalva, but on MRI, there is no evidence of any dilated veins, and it is a well-circumscribed lesion with molding and phlebolith. So, there is a confusion that whether we should tell it a hemangioma or varix. So, house is open for discussion, and I would like to get your inputs.
Any comments by anybody? See, actually, it looks like a case of venolymphatic malformation with a predominant venous component. Right? It behaves somewhat like a venolymphatic malformation, but also has the characteristic of a varices. But it is not a hemangioma because, as you showed on the MRI, it is molding on the eyeball. Hemangioma actually presses the eyeball. Here it is molding on the concave surface of the eyeball. So this is more likely to be venolymphatic malformation with a predominant venous component rather than a lymphatic component.
Yes,
and those patients do present with acute proptosis because of intralesional hemorrhage, which you showed very clearly, which spontaneously resolves as it happened in this patient.
Okay.
So yeah, that would be the diagnosis, most likely. Any comments from anybody? Raman? Okay. Vishal? Nobody? All of you do oculoplasty. Do you have any comments? Becca? Shalini? Okay. So the best possible treatment even in venolymphatic malformation and predominant venous component is sclerosing agent. In a cold phase now that the patient is, you can inject bleomycin under, since it is mainly in the intraconal space with little bit of extraconal extension, you'll have to possibly do a CT guided bleomycin picibanil injection.
Okay. So, but already there is a component of inophthalmos. So, if we give
Then
this
you can leave it alone. You can leave it alone. Explaining the patient
as
that
of now, his own conservative management
all right.
and follow-ups.
Okay. Thank you.
Thank you, sir.